Welcome back to Voices in Health and Wellness. This is the show where we sit down with pioneers in health, functional medicine and mental well-being to explore how care is evolving. I'm your host, Dr. Andrew Greenland, and today we're joined by Dr. Jeffrey DeSarbo, an award-winning neuropsychiatrist, the medical director of ED180 treatment programs in New York, and the author of the soon-to-be-released translation, Demystifying the Neurobiology of Eating Disorders. Jeffrey brings a unique voice to the world of psychiatry, blending neuroscience, existential psychology, and preventative medicine to explore not just how people recover, but how they thrive. His book, The Neurobiology of a Bucket List, unpacks how purpose, meaning, and proactive life choices affect brain function, behavior, and long-term well-being. Jeffrey, thank you so much for joining us today, and welcome to the show.
Thank you very much, Dr. Greenland.
So if we can, perhaps we could begin a little bit with your background. How did you get started in psychiatry, and what pulled you towards neurobiology and eating disorders specifically?
Well, I'm actually one of those people who took an unusual path into medicine, in that my original degree was in banking and finance, and I worked in the city. And after a few years, I felt I wasn't being fulfilled very much with my life. And I came home to my wife after a business trip and said, I think I want to be a doctor. And she was a little caught off guard by that because I never talked about it. Long story, I did apply to med school. I was married. I had 2 little kids. I found my way initially wanting to go into pediatrics because I would go in with my kids to their doctors and have to wait too long. And I thought I could run this better than that. And in medical school, I did my rotations, and it really was when I hit my psychiatry rotation that I kind of remembered what I heard on my first day of medical school, which was, if you love what you do for a living, you never have to work a day in your life. And doing that psychiatry rotation, up until that point, I had no real strong direction or pull to go in that. I was at that point thinking of infectious disease. But my psychiatry wasn't like work, and I just loved doing it, and my interactions with people and everything. So I gravitated, did my psychiatry rotation. I did it on Long Island through the NYU program at North Shore Medical University Hospital. And during that, 2 of my advisors when I was a resident were pioneers in the field of eating disorder treatment. And so I think they were an influence on me at that time. After graduation, I started working with patients. I just really developed this fascination with really trying to understand better the functioning of the brain and psychiatric conditions, especially with eating disorders. Because one thing people may not always be aware of is people will always say, why did I choose eating disorders? Is you go through medical school and you learn all this background in medicine. And the thing about an eating disorder is it really is half medical, half psychiatric. So it allowed me to kind of utilize all the knowledge that I had acquired through medical school and residency. But really learning about the brain became something that, once again, it wasn't like work. I would read articles just constantly about how it affects our cognitive functioning, our emotional functioning. And it was just something that never stopped.
Thank you. And that leads us nicely to the next question. Could you perhaps talk a little bit about ED180? What's the philosophy behind it and how it's evolved over time?
So ED180 it's something I created right after I started my private practice, and I was seeing patients, and there's not a lot of experts in the field that truly understand the nuances of the eating disorder and the language that goes with it. I always say it sounds English, but it's not. There's a lot of tricky nuances to what someone says and what they mean and what they hear. So ED180 was something I started in my office space, having therapists working with me and having nutritionists working with me, and another psychiatrist who actually specializes in addiction was in my office. And I put together essentially an intensive outpatient program, and also had a partial hospitalization program going with it. And the name ED180 I chose because we use the ED, or we say ED. We will often refer to the ED voice in a person. It's not a schizophrenic voice, but it stands for eating disorder. And a lot of people think ED180 stood for the 180 is turning things around. And it does have that. But from a neurological point of view, I've always learned how when you want to make significant changes that stick in life, it takes about 180 days for that wiring to really start to form and stick. And that's how I came up with ED 180, and which became more of an organized IOP and partial hospitalization program, which it ran pretty much uniformly as that up through COVID. Once COVID hit, things took a change. Now with ED 180, we kind of put together customized programs for each individual depending on what their needs are.
Thank you. So what does it look like from a patient perspective? What's the patient journey on somebody who's embarking on this program?
Well, it all depends where that patient is. Is it someone who's new? And if it is, then there is a lot of psychoeducation involved. If it's somebody who's been chronic with this disorder for years, then it's often us doing intakes and trying to find that unique individualized approach that hasn't been tried. There's been a lot going on, a lot of talk in my field right now of palliative care. And sometimes, well, we tried everything. Maybe we need to give them kind of an end of life plan. And that's not a view I've ever had. I've always felt there's always something different. There's always something that hasn't been tried yet. So depending on where they're entering their program, they'll meet with myself. I always say, if you want to look at what's a gold standard package, it's usually they have to have their physician, their nutritionist, their therapist, which is key to it. If they can have group therapy and as well, the psychiatrist may or may not be a part of that, but it often is. And so we're working as a team to try to help an individual. It's a very labor-intensive process for one patient. And you're hoping that most people on that team really do have some specialized background and training in eating disorders. So.
Thank you. And moving on to your book, what inspired you to write The Neurobiology of a Bucket List, and how does that concept play out in clinical or preventative settings?
Well, I do. It was something that I was heavily influenced, I have to say, by my father, who was a blue-collar worker. I grew up in a blue-collar lifestyle. He was a printer for the state of New York, and he developed a renal cell carcinoma, kidney cancer, and he lived with it for 17 years. He had retired at that point to kind of just take care, because he didn't know how much time he would have left. And during those 17 years, I always let people know he lived more in those 17 years of life than I think he did when he was without the diagnosis and living. And he said to me one day when I was looking to buy a house, he said, "Don't put all your money in a house." He goes, "There's a lot of things to see in this world." And it really stuck with me. And that's when I actually first got my passport. I've only had that passport for now maybe 12, 13 years, but what he said and the stories he would tell me had me doing as much as I can with my time remaining. Of course, my interest in neuroscience was always a part of all of these types of experiences, whether it's travel, trying new things and everything. And my father had passed away about 7 years ago. And I realized how it all kind of came full circle and it tied in. And when I studied the brain with the things we do with a bucket list, it has this kind of, like you said, preventative anti-aging effect. It works so well in conjunction with other things people do to improve their life as we age, with exercise, eating well. But the studies that I kept coming across and reading about goal setting, about intentional living, it showed how our brains still remain plastic. We're forming new neurons, new connections. How do we keep our own body's production of things like dopamine and serotonin elevated? Because once we reach 40, they start declining by 10% per decade. But living with this novelty and new experience helps keep the brain's natural ability to produce these types of neurotransmitters elevated. So it's like I said, you can take care of yourself, but you still have to live a life that's kind of active and novel and challenging. And when we meet people, we can see that. When we meet somebody and they tell how they're living their life, we almost sense there's more of a vibrant energy within them. So, that to this day, I have to tell you, that's been the biggest thing. And I'll do the most crazy things that I don't even, I always say, like earlier this year, I took acting lessons. I have no desire to be an actor, but I enjoyed it so much. I could feel it working in parts of my brain that I've never turned on before. And it had social context. So my oxytocin was working well and everything. And those are the types of things I discuss in the book, because it isn't just about making a list and checking things off you want to do. It's really living kind of the semi-structured bucket list style approach, takes all the principles of neuroscience, of novelty, and it puts them into action. So we're always learning, and it's been something now that I see through even the people I've worked with. Sometimes in my own office, we'll discuss their bucket list plans, how to go about it. They have most of my patients pick up my book, and I even developed an eating disorder supplement based on the main book, which I did want to share. I'm proud. It's felt great. I've given away now over 1,400 free PDF copies of that supplement book, which is on Amazon, but I have a category called legacy. Okay, it's like or giving back in life, and for me, that's something that I did during the Thanksgiving season this year, and I'm telling you, it's been overwhelming. The feedback, the appreciation, it's boosted my dopamine and serotonin. I wanted to even do more of it now. That book that you mentioned, the neurobiology of eating disorders I have coming out, that's the type of book that goes for close to $200 on Amazon, because it's almost like a textbook. But I'm already sitting there thinking, for people in my profession, if they want a free PDF copy, I'll give it to them. So if anyone does see that when that book comes out, I always tell people, just send me an email. I'll send you a PDF copy. I'm not an author. I have my daytime job.
Okay, well, very happy to promote it on the podcast page if that's helpful. Don't want you to get overwhelmed, but I'm very happy to do that for you if that's helpful. So there's an awful lot to talk about preventative medicine, but I think you've referenced preventative psychiatry in the conversations we've just been having, and some of what you're writing in the books kind of comes to that. So what are you seeing that makes this more relevant today? What shifts are you seeing that make preventative psychiatry more relevant and more important?
Well, it's almost that there's been, I could say since COVID especially, but I think we can go back before that, in the sense that we're getting blasted in the media with the type of information and the manner in which it's presented. Because my initial degree was in banking, finance, and my first job was with marketing and marketing research. The one thing that I recall all the way back then is like the two human emotions and drives that in a market-driven economy, media wants to create in an individual is fear, anger, anxiety and anger. And that's what keeps people tuned in to social media, to news stations, to newspapers, okay? And that's what sells advertising. But we've become very good, and now with AI, of learning how to induce those emotions in people. And it's done on such a seductive, unconscious level that we see a lot of intolerance, a lot of anger. So now more than ever, taking a proactive approach in preventative health, especially with our minds, is so important. It's interesting too, because like even in therapy, I think people are becoming overwhelmed. They pull away from therapy a little bit. Now's the time to go into it, to stay on top of it. I always say a good therapist is somebody who helps keep you thinking in top form. I always will say to people, when Serena Williams was number one, she still had a tennis coach. When Tiger Woods was number one, he had a golf coach. When all these people at the top of their game still have coaches. They're not better than the players, but they have somebody there to keep them kind of like on track. And to me, even therapy is very preventative when you have that connection with a therapist who helps you thinking and functioning in your peak performance zone.
Thank you. So is there a growing openness amongst patients and clinicians towards more lifestyle-driven brain health? I guess by the response to your PDF promotion of your book, you'd probably say yes, but so more outside of that and in the wider world, what would you say about the openness to this?
Openness, again, clarify for me. You mean like how
Towards lifestyle-driven brain health, because it's not banded around. It's not a term I've heard very frequently, but you're really making emphasizing the importance of it. And I just wondered whether it's something which is catching on and people are kind of getting into.
Well, I think it's something that's catching on almost more than ever. The question is like, it's like I'm somebody who always believes with mindfulness approaches, we have to learn how we live in a gray area. So I think since COVID, there might be something going on with younger generations where not only is it catching on, it's all about lifestyle. It's like, no, I don't want to go to work. I just want to work from home, and I only want to work 20 hours a week, and I want to play. For other people, there might be a fear that's going on. Their anxiety prevents them from trying to find that balance in their life. So I think the key is, how do people find kind of a balance between living a lifestyle where they still are productive and they, can take care of themselves, responsibility, but not to the point where they're so stressed with what they're doing that it's reducing their own productivity, not just with work, but with productivity with family, with productivity with balancing their stuff so they have time to exercise and do other things that are healthy with their lives. And then, of course, ever since COVID, my concern and worry has been increased use of self-medicating with things like alcohol, THC, and other substances. So when you use the word lifestyle, that is the word to try to figure out for longevity and happiness and feeling a sense of purpose through balance with doing things with like kind of a bucket list approach, as well as still finding ways to get done what we need to do in this world. So
thank you.
I hope that answered your question.
No, it does. Thank you very much. I remember you've got an upcoming talk to the New York State Society of Physicians.
Right.
If so, what are you hoping that your peers are going to take away, especially those who might be nearing burnout themselves?
Yeah, that's actually one of the learning objectives that we always have to say. It's like, how do you prevent burnout, especially with physicians in healthcare? And when I found out that they were doing this and they reached out to me, I didn't even know that New York State has a special initiative program that they've been doing on physician wellness, which I think is very good. And so when I work with them, it is talking to them about thinking about themselves and implementing a plan that helps them, again, find that balance between their life and the demands, especially with the things that have been going on in healthcare. And as I'm sure you're aware, in the US, there's been some changes in the way people think about healthcare. There was an announcement about a post on a CDC website. My friend, who's a psychiatrist in Arizona, reached out and just sent me this text and said, "Okay, that's it. Medicine and science is officially over in the U.S." So hopefully, I can talk to I'm going to use the outline of what the concepts of a bucket list is, because again, it's not about just picking things you want to do and travel or skydiving. I always use it. There's an acronym that is what I think a bucket list is all about, that helps with physician wellness, anyone's wellness. It's called IPIG, not iPod, but IPIG, which means it's intrinsic, means it's living a life that is something that means something to you. The P is it has that purpose to you. The other I is that it's intentional, meaning it's not things that are just happening to you in life and you're reacting to them. They're intentional decisions on a bucket list that you make for yourself. And the G is it fosters more gratitude. And that's what a bucket list. It's not, again, whether that's through travel or skydiving or going for walks around the block or appreciating sunsets and painting and photography. That's the intrinsic component for each individual. And, I think when it might seem obvious, but when we're living in a world that's kind of becoming more and more chaotic, it's so easy to forget the obvious. So.
Thank you. You've referenced COVID a few times in the discussion. How has your own thinking shifted since COVID in terms of what patients and clinicians really need?
Well, that's another component that it really did shift a lot, even in my profession. So much now has become telehealth, and there's studies out. I recently wrote an article that was in Psychiatric Times about the article was titled "Beyond Convenience," and that medicine, it's like people just, especially in therapy, psychotherapy, and everything. It's just easier to do it virtually. But I talk about how we have to proceed with caution, especially when I work with difficult cases of eating disorders, or there may be difficult cases in substance use and things like that. The office visit, I feel, still gives us so much more information than virtual. But virtual has also opened up therapy and treatment to a lot of people who otherwise wouldn't have had it or wouldn't have invested the time. But I think we're in a period where there's going to have to be research in the true studies that say how effective is it, because most of them right now seem to be saying, oh, it's almost equally effective. But then I look at who did the research, and it's often coming from centers and stuff that are doing it virtually. The other thing was what happened with COVID is self-medicating seems to have skyrocketed. Alcohol use disorders are way up. There seems to be also so much more anxiety and even rates of specifically of like obsessive compulsive disorders, illness anxieties that have skyrocketed in my clinical practice, almost doubled. Okay. So fear, anxiety, I think COVID really shook us up in the world, and it led to further division in our society with people and who should be vaccinated, why you shouldn't get vaccinated, all these things that this has done, not to mention what it did to the youth and taking them out of schools and the effect that's had both socially and academically on them. So there's a lot more anxiety that's popped up since COVID. So.
Thank you. And obviously that your practice and the platform and the programs are all businesses in a sense. Looking at them as businesses, what's working particularly well for you and your team? What are your kind of success stories, the things you're proud of in the way that these things kind of pan out?
Looking at what business?
From a point of view, your practice and the programs that you run, they are essentially businesses at the end of the day as well. I'm just curious to know what's going particularly well, what's working for you in this space.
I think what's always worked for well in this space is the therapist and the nutritionist that I have in my office, because I'm there, and we've always been a close-knit group. All of my therapists and nutritionists do have a strong foundation in the neuroscience of treating eating disorders and the brain expectations. We're able to talk to patients about this in terms that they can understand and relate to, so that they know that it's not just that, it's a character flaw, or all you have to do is just eat more. And, like everyone in my office has an understanding of what drives the process. I also think the people that I work with, we all have the same type of personality. We're relatable. We talk to people, which is so important in this field, because one of the main factors, when a person says, I feel fat, and they have anorexia nervosa, the acronym we use to that is that they have fear, anger, and trust issues. So having that ability to talk, communicate with the people we work with, it's a process that we have to earn their trust and understand their fears and their anger and anxiety with everything. So I do think that from my own perspective, that first and foremost, it's the people you work with in this field. There has been a trend where if we go back like 2 decades, pretty much every treatment center was privately own and run. People would make hiring decisions on staff based on experience. There's been a little concern now that the venture capital firms have come in and pretty much bought almost all of these eating disorder centers, and it shifted from a little bit more from patient care to profitability for their investors. And so sometimes I certain places, not every place, but certain places, the caliber of people working in treatment has suffered. But the one thing I think, like, I've never been in that realm. I've always been able to work with the people and bring into my office the people that I want to work with. And I think that's one of the keys. So.
Yeah, you can't overemphasize the importance of a good team.
Right.
On the other side of the coin, what are some of the challenges in doing this kind of work, or bottlenecks, or things that you really struggle with in the business?
Well, I think because we are so dedicated, maybe at times, we do feel a sense of more responsibility. It's not less like we're seeing a patient. Okay, I'll see you next week. And it takes a lot of practice. We have to have our own training and how do we deal with this so we can go home at night and not be able to sleep over some cases, because eating disorder cases still are one of the highest mortalities than anything in psychiatry. And so there's a complexity to the treatment. Like I was saying with the team, is it's important you have a good team, but you have to collaborate. It's not like if I was treating just anxiety or depression, someone can come in, I can talk to them, maybe prescribe something. It's like I have to be in touch with the therapist, the nutritionist, the doctors. So that's what I say. It's a much more labor-intensive process, and sometimes when we have multiple patients who are struggling, it can be a little bit overwhelming. And that's the day sometimes I think, well, maybe I should just specialize in ADHD, and they can come in, I can give them a med and it works. But no, it's my dedication to the field is something that I feel strongly about. And again, because I've worked with others, it's made the effort and the difficulty at times much more tolerable, because we also share in that empathetic outlook we have in caring for our patients. So.
Thank you. And what do you do to look after your team, given everything you've just said about the risk of taking stuff home, sleeping on it, burning out? How do you support your team specifically?
Well, I know at times I'm kind of in a little bit of a leadership role, and my personality, people who know me on the outside, and even my patients know, I try to teach, like, with everything that's going on, you have to not take life seriously all the time. You have to be able to, again, keep that balance in life with doing things. So I think what I try to do is I try to set an example, of hard work balanced with the myself living that bucket list lifestyle, but also I don't panic, under some of these situations. And the thing about having someone new come in and learn this, how do you treat a patient with a severe eating disorder, is if you don't, you just don't panic, because I see that in my field all the time outside of, my office and everything. And if you panic, then the patient picks up on that right away. So I think it's just, I try to lead a balanced life, a balanced approach, not take life too seriously, except everyone knows how seriously I am about the treatment itself, But so I think lead by example is my approach to trying to help the people I work with. I hope it's worked through the years. So.
I'm sure it has. If you had a magic wand and you could solve one persistent challenge in your practice, your specialty, your field, what would that be?
What a great question. Well, it's interesting. I think it's access to treatment, and I think it's also we're learning more. And when I talk about the neuroscience, I really want all clinicians to understand that aspect. A psychotherapist may not have a specifically strong background in neuroscience, but a lot of the stuff I try to put out there for people, including, like I said, just tell people, here's this book. If you want it, just take it, read it. Like I think my magic wand would be in the form of educating people in what we know, because we know, in my view, some of the stuff I talk about or write about is 10 levels above where we were 10 years ago. But sometimes I think people are too busy in their own lives that the continuing education component of treatment and being a clinician has fallen. It's suffered, And so yeah, my magic wand would be people continue to take a strong interest, educate themselves so that they can then apply that to treatment plans and working with people.
Thank you. Good answer. Obviously, you are running a business, you're clinical as well. What's the biggest time drain for you in the work that you do? Obviously, there are things that you're passionate about and you love to do, but I'm sure there are things that are less palatable, should we say. What would those things be?
Well, it's funny when you say that, because yeah, it is. It's the time management of everything. So the time drain, and I feel at times there's so much I have to learn and remember that I, couple that with my own ADHD, it doesn't make it easy, but I have to stay on top of multiple cases and what's going on or what may be getting off track. I have an incredible office manager who's been with me now for close to 2 decades. And she's really a key part of what I do. Her name is Tamara, and she's from Australia, and she came here and she met somebody that she wanted to marry. She needed a job, and she was the perfect person. And what's so interesting is just by working with me, the education, like she can talk and handle my patients for me on some issues that aren't, medically related. But the time drain comes with the multitasking, because again, it's not having a patient with depression, a patient with anxiety that I just work with my end. It's this multiple patients, each patient with a unique presentation of their eating disorder and the need for collaboration and multiple, issues going on. And as a as a psychiatrist that works with eating disorders, again, I probably order more lab results. I interpret lab results. I have to tell patients, when you go to your medical doctor, I need you to ask them about this. I need, at the same time, as physicians, we learn, right? Like physicians hate other people telling them, what to do. So I'm delicate with that, But then again, there's some physicians that are great that say, oh, okay, yeah, I need another DEXA scan. And okay, no problem. They actually appreciate if they don't have that specialty and that additional collaboration and input that I can offer without, again, walking that fine line of not being a pushy person, So.
Thank you. I guess there's no shortage of work in the eating disorders field, but if you had a sudden surge of inquiries next week, what part of the system would bottleneck first? Hopefully not you.
The part of the system here that really bottlenecks the system is accessibility, finding people who are qualified, and affordability. Our insurance companies here do not want to pay for eating disorder treatment. They're not specialists who do the assessment as for coverage for the most part. When I've needed to get extended days in a hospital or something for a patient, the person I'm talking to, I feel they don't understand this at all. There's been a recent change that I hope is going to take effect, but they'll just look at, like with anorexia, what's a person's weight and BMI? So, well, then they can be discharged without any other safety concerns or anything. They really don't understand nuances of severe binge eating disorder or bulimia nervosa. So the system is far from just even being adequate, and it's insurance driven, but it's not being driven in a form that I feel, it's again about profits. It's not about a patient's well-being and bottom line. And I get it. I understand there's an economic component to it, but there are so many people with eating disorders that have subpar treatment that it's simply because of affordability and then accessibility. Once again, I think the thing with accessibility is with virtual now, you can have access, if you're in the middle of the country with no specialist, that you can still virtually connect with people. But even that, it can be expensive because it's not like somebody just needs a psychiatrist or just needs a therapist. Don't forget, they need that team. And if they can't get coverage on it, it can be extraordinarily expensive. And I would often do talks, and patients and family would come up to me and say, look, we have Medicare, we have Medicaid, we can't find the right treatment. What recommendations do you have? And I'm almost like empty with an answer. There are some nonprofit groups that try to help people, but they cannot cover the amount of people that need further assistance. And I'm a little worried where the future's going with that. So,
yeah, no, I hear you. If you were starting ED 180 again from scratch, would you do anything differently from, based on your learning and the journey you've had so far?
There's nothing that pops right to my head. I think I tried to do it, the best way. I think there is a format to it, and I've always had the right people. The biggest thing with ED 180 goes back to the same thing too, is how do you form a program that you can make affordable if somebody can't get it covered? And usually, like I said, they don't want to cover it. It's like when I ED 180, 180 days to make changes that last in the neural system, How do you get somebody to cover 180 days of treatment? It's difficult if somebody lacks the funds, and it's difficult to get any insurance company to do it, and they'll find okay, we have a couple centers we can recommend, and they're not always the best centers, So I guess I'd hit the lottery and then I would fund it myself if I could. That would be my change. So.
And what's next over the next 6 to 12 months? Are you looking to expand the clinic, publish more work, or reach more broader audiences for education, all of the above or none of the above?
I would say I have, within my own bucket list, writing has been both a mindfulness exercise for me that I enjoy a lot. I with the book and the eating disorder supplement book as well, I consider that my contribution to education as well. I want people to learn about their brains. I want people to learn that there are things you can do in your life where they're intentional, they're proactive ways to help recover. I've learned how incorporating this intrinsic approach, I always say in eating disorder treatment, there are things that push people through towards recovery. That's your clinical team, your treatment plans, your nutritional plan, your medications, and then there's supposed to be things that help pull you through. And that's what's the existential kind of reason for you to go through all this treatment that's very difficult. That's where I felt my bucket list plays a role, is it gives somebody an extrinsic reason that helps pull them towards recovery. So I've been on that process. I've been writing in general because I think this is, in today's world, this approach is such a important, needed way to try to think to counterbalance all the stress and chaos in the world. And, I created this website, bucketlistdoctor.com. I don't know if you had a chance to see it, but if you go there, it's a fairly new website, and I must have 20-something articles that talk about that bucket listing mentality, how it affects the brain. It's got the emotional components to it. I talk about why I've written the book of the eating disorder supplement. So I think I'm in this phase of wanting to provide education. And like I mentioned before, I want to give back to my profession. It's been a rewarding profession to me personally, intellectually. They always say it's nice to make a difference in the world. I think that's why we do this a lot. We try to help people. And I always tell someone, you don't have to help the world. Sometimes just helping one person really means you contributed. And so I like that I'm hopefully have helped one, maybe a few more, and I want to continue to help not just people who suffer, but I think with my education, I'm trying to help people who are trying to help people who suffer, so kind of multiplying that ability to maybe leave my mark in that way. So
amazing. Jeffrey, on that note, thank you so much. This has been such a rich and honest conversation. You've got a really compelling lens, not just clinically, but philosophically. And I'd really like to thank you for sharing your time and your brain with us today. So thank you very much.
Thank you.